region, and I am the sponsor for our Safety Expo that we're having this upcoming week. We're kicking off this session by an exciting day where we're having our patient representatives come and tell you their story. From what I'm seeing, we have a lot of attendance out in telehealth land, and thank you very much for taking the time out of your day to be with us over the waves. And also for the people that are in this room, thank you very much for coming. Our patient representatives are very, very important to the work that we do in the Cypress Health region and to making the improvements that we need to make in our healthcare system for their family members, for other patients, and for themselves. And so, with that, I would like to turn it over to Susan Stolzen, who will introduce our panel. And thank you very much for being here today.
Welcome, everyone. This is a very exciting day for Cypress Health Region. This is our first ever patient panel facilitated. So we may have some bumps in the road, but I think we're going to move forward. So for those of you I have not had the opportunity to meet, I'm Susan Stolzen. I'm the Director of Quality Care and Patient Safety for the Cypress Health Region. Patient family-centered care is one of the roles that underlie my title. The patient panel provides the audience with a snapshot of a patient's or family members' personal experiences with the healthcare system. Sometimes telling a story is a doorway into someone else's personal space. You may be able to relate to the stories on a personal level or know someone that has experienced the same. Whether it's a positive or a negative story, we can gain so much by listening and hearing, understanding how our patients and families have been impacted. Our hope is you will be able to take away one small piece of what you hear today. Nothing about me without me. This statement captures how the voice of the patient has evolved and has taken healthcare from a model of care where care was determined by the providers to patients directing their healthcare needs. As I said, one part of my role is to coordinate patient family-centered care, PFCC as it is commonly known as. You may be asking, what is PFCC? The definition from the Institute of Patient Family-Centered Care defines it as an approach to the planning, delivery, and evaluation of health care that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families. It redefines the relationship in healthcare. Simply, it is patients, families, and care providers supporting each other so that informed decisions can be made. I find myself fortunate to be able to listen to patients and families on a daily basis. It may be as simple as navigating them through the system, connecting them with a program area, or arranging a case conference. The satisfaction that I get by being able to help someone work through their questions, concerns, connecting them with the right program area, or advocate on their behalf is truly satisfying. We as healthcare providers, whether we are a frontline care provider, administration, or support staff, all need to embrace the knowledge patients and their families have. They truly are the most educated on their own or their loved one's health. We are extremely fortunate to have present with us today Mallory Keller from the Health Quality Council. Mallory is the provincial lead for patient family-centered care. Mallory is one of the most knowledgeable people I have met in Saskatchewan for patient family-centered care, and I appreciate that she has taken the time to come with us today. Mallory brings with her years of knowledge and experiences on the core values, concepts, and principles of PFCC. Thank you, Mallory. So getting to the good stuff today is I am excited to introduce to you the patient representatives that have agreed to participate on the patient panel. I, myself, am humbled by their stories and honored they agreed to share them with others. I have Melinda Baum, Brenda Andres, and Leanna Kong. I'm going to ask them to take a few minutes to go over their biographies that we circulated for them to tell us, and really it's getting to know them. So before we start the panel, If each of you want to take a few minutes and go over that, and then we'll get started with the panel. Thank you.
They forgot what they wrote down and what they had prepared, so we give them an extra copy.
Hi, my name is Leanne McConnell. I have been a patient rep now for 4 years, and I'm here today talking on behalf of my family, as I myself have not been a patient, but my children sure have been. I'm a piano teacher to 40 students in my home and have been teaching piano for about 35 years. I'm the wife of a building contractor, and we have 27-year-old twin boys that were born exceptionally premature. They're only children that we have, and they were born at the Saskatoon University Hospital. So the experiences I speak of today will be from that health region up north. Our children were born at 28 weeks gestation. After they were born, our lives took a turn, to which included using the medical system extensively. One of our boys was in the hospital for only 2 months and was diagnosed later on to have mild or moderate cerebral palsy. He uses a wheelchair to this day for full-time mobility. Our other son was in ICU and then PICU for the first 4 years of his life, which now, when I think about that, it's incredible to me that we got through that. And then finally came home on 100% oxygen with the tracheostomy, which involved a lot of care as well. I would say that we have used almost every aspect of the medical system at our disposal over the last 27 years, from doctors, surgeons, nurses, physio, occupational therapists, speech therapists, dietitians, social workers, and the list goes on. Our experiences have been many, with our boys having 19 surgeries between the two of them. Our one son's condition even took us to Vancouver Children's Hospital and also to Toronto Children's Hospital. My husband and I have done our best to raise our kids to be healthy and very special young men, and we're so happy to still have them in our home as our journey still continues with them. And you know, we hope that they can live with us a bit longer, and we're enjoying, you know, doing that. So,
Thank you.
Good morning, everyone. I'm Brenda Andries, and my other name is Grubby because I am a mother, I am a daughter, I am a grandmother. And I was born and raised here on the prairie in the southwest corner of Maple Creek. And one of the things I would like to tell you about today, and I get a little emotional when I talk about it, is about my mother. My mother was the face of healthcare in our community for 50 years, 60 years. She was a nurse. And when my parents were diagnosed with their cancer in 2010, it was a real struggle because the care and the attention that they needed was not available to them in our hospital. And so they had to go outside of Maple Creek to get what they needed, where they needed it. And it was a real struggle. And to tell you that I got angry, that I went ballistic, that I went public, were things that were feelings and emotions that when I did that, my mother came to me and she said, "Bunna Jean, you have embarrassed me." "Mom, what are you talking about?" "Brenda, I worked in the healthcare field for this long, and your comments were very difficult for me to hear and to manage. And so I said, "Mom, I will never embarrass you again." And so I turned all of that anger and frustration and negativity around, and I made it something that grew beyond anything that I thought that could be possible. I got engaged, I got involved with the healthcare system, and I began to see from the inside out just exactly what it is and how it is that our healthcare system works with me, with my family, and is helping when I thought for so long that it wasn't helping. And so the most important message that I could give about my experience and about why I'm here is because I am the voice for my family. I am the go-to person, and they rely very heavily on me to be that voice for them as we go forward with the healthcare system. And the issue around that is that of the various members of my family, and I've talked a lot about my twin, and your twins, my twin is probably the longest surviving AIDS patient in the province and the country. He has chronic, long-term health issues related to medication, AIDS, that kind of thing, and he depends on me. On the other hand, I have my sister who went to the hospital 3 times in her life, and each and every time, well, how does it work? What am I supposed to do? How do you fill a prescription? It's like, it's crazy to be in the middle and to have to represent that and be a part of that. But at the same time, they rely on me. And I have to be mindful that they do come to me with trust and caring as I come to you with trust and caring. And it's so important that that be a positive exchange. So that's my message for today. I'm the voice for my family, and you are the positive provider that I need to engage with.
Thank you, Brenda.
Right?
Oh, that's great.
Get carried away.
Go ahead.
And I'm Melinda Baum. I'm a social worker in corrections, but I love being part of the patient representative group because I think I understand somewhat both sides. I think I understand the need to be accountable as a public servant or a civil servant, as we all are. And I also understand the perspective of a patient. And I too have seen the medical system at its worst, and I have seen it at its best. And I think we get so busy with the accountability parts of our job that we forget sometimes about who's in the bed and who are we serving. And I think it's not because of anything other than a desire to do well and to hit the check marks of what we need to get done and the expectations. But what gets forgotten is that the person in that bed is the most vulnerable they'll ever be. And the dignity of that person is never more at stake than when they have a hospital team caring for them. So those are the parts of my story, I think. Other than that, I'm also a mother, 2 boys and 2 grandchildren. And the latest news about my life is that I recently became a Canadian citizen. I've lived here since I was 7 years old, and I'm 54, so do the math. And I finally took out my citizenship, and my husband was so tickled. I said, well, if I would have known it was this important, I would have done this a long time ago. It was like I lived with him all these years, and then I finally got married. And so I am a Canadian, and I got to vote for the first time in my life, and it feels pretty good.
Thank you so much for sharing. So today, my role is facilitator, and I want you all to look at what I am doing and learn from the questions that I ask. The questions that I ask shouldn't just happen when we're having a formal event. They should happen every day. Talking to patients and families, finding out what makes their care exceptional, what their challenges are, what are things that we could do better to improve their day or improve the care they're receiving. Those are everyday questions. So we're going to ask them today in the construct of this panel, but I hope that each of you write them down and actually seek to talk to patients and families in this way each and every day. So, who's going to start? Melinda.
Okay.
Alrighty, so share an experience where you received exceptional care and tell us what made it exceptional.
I can pick a couple of things, but I think I'll talk about I was in the middle of 4 years of medical surgeries and all over the place, but in the middle of all that I broke my leg, and so I ended up going to Saskatoon, to the hospital in Saskatoon, and of course they're very, very busy there. It's true in so many hospitals that it feels like a whirlwind around you, and people just have the next thing on their checklist to get done, and all the things that haven't been done and need to be done from the last shift, But what I found when I went there was, despite me feeling like a nuisance because I was in the hallway and then in some room like we have to do when there's too many patients and not enough beds, what I found was a nurse that would say, I am so sorry that you have to be here. We hate it when we have to do this. And that made all the difference. That alone just relaxed me. I'm going to be okay. All she had to say is, I hate it that we have to do this, but you're here and we'll get you a bed. And then she said, I'm really worried that I'm going to forget to get your supper at that time and you don't have a bell. So we need to figure out what you're going to do so that we make sure you get your supper. You're going to need to eat tonight. You know, those kinds of things. It just made the difference when she would say, I'm busy. I know I'm busy, but I don't want to forget about you. You're important. And those things made a lot of difference. What I saw on the ward too was also people crammed in everywhere and a busyness, but what I saw was that the staff liked each other and that they spoke highly of each other and highly of the next shift, and they teased each other. And I can't tell you what a culture that presents to a patient, where people they were having fun despite the crazy busyness. They liked each other and they respected each other, and that culture that you develop is a culture on a team, on a ward, and in a hospital. And if you can develop that culture, that goes so far in making patients feel safe and comfortable and taken care of, because the people that work there like each other. And that's such a small thing to remember, that you're people too, that when you're ticking off the boxes, you know, that needs to be done. There has to be accountability. But when people talk about care, they mean the care of the patient. It's not whether people made mistakes with needles or medication or those kinds of things. No, it's the care that the culture of the place presents to me.
That's a great answer. So I think, you know, just listening to what you said, often we do find ourselves that we are busy, and we need to remember to instill that respect and confidence in the shift that comes after us, as well as in all the other providers that you're seeing. So I really appreciate your response. Brenda, same question. So share an experience where you received exceptional care and explain to us what made it exceptional.
Well, I want to talk about Brian, my twin. And we got this twin thing going, he and I. There's never been a moment since my conception that he hasn't been a part of my life. And it's really, he depends on me so much to be the one to speak up for him, fight his battles, be his voice, do what he needs to have done. And when you're an AIDS patient, there's a very negative connotation. It means you've done something bad. And you know, you may not have done anything bad, but the issue is that connotation, that kind of a diagnosis goes with you. And so throughout his life, and Brian was diagnosed in 1983, so you can imagine how many years of interface he's had with the healthcare system, and in places like Calgary and Saskatoon, and in the last number of years in our small community of Maple Creek here in the Cypress Health region. So he's had some extremely negative kinds of experiences, and they followed him through his time with the healthcare system, and he's still here, so that's the good news. But I had to negotiate, and I had to approach it, and there's a very fine line as the advocate as to what you can do or how you can, because you don't want to take over the whole life of your family member. You want them to have their voice, but they want you also to have your voice so that their voice can be heard. And with Brian, it was really simple little things. For example, he is extremely anxious. If he was in this room, he wouldn't know where he was or what day it was, but he would be feeling extremely anxious about being here. So it's making him feel comfortable. It's making him feel like he is a part of what is going on around him. And we really struggled with that initially in Maple Creek when he got there, because there was all kinds of blips around how things should happen. Like, you have to get the blood to the provincial lab by cab on Monday from 2 to 4 or from 8 to 10. And there's very fine timelines as to when procedures or diagnostics can happen. So I don't know, mostly because I was able to speak for him, that I would go to the lab, I would go to the doctor, I would go to the clinic, and I would say, you know, he's a little apprehensive, he can't sit in the waiting room, can we make some arrangements where things can happen for him in a more comfortable manner for him? And through negotiation, it's like, here's the best example. Flu shot. I hope you all got your flu shot. Last week, he went to get his flu shot. He walks in the door of our brand new, beautiful hospital. Hi, Brian. How are you? You know what? He didn't know a single person there, yet he's been coming there for 10 years. Oh, buddy, he said, they were so good to me. They called me by my name. They knew me. I didn't know them. But by goodness, they sure were nice. It was like going down for morning coffee. I'm being funny when I say that, but the truth of the matter was, it was because they were welcoming. It was because they knew who he was, and they knew his little quirks and idiosyncrasies, and were able to invite him to be a part of the process that was happening. And that happens a lot. Even Dr. Joe, you know, who's very busy, takes the time, and because with Brian, it's all about the shirt, right? If it's starched and buttoned down, and you notice that he's looking good today, that's real, and that's important. So it's not always about the actual procedure, the diagnosis, or whatever it is. It's about taking the time and being there, and that made him feel safe, and it was quality, and that happens on a regular basis for him. And that's, you can't know as the healthcare provider how we as the family, we struggle with, is this going to be an okay experience today? Is this going to go as we'd like it to go? Is it going to be okay? Are we going to come out of this okay? And we do. And I don't say he, I say we, because, you know, we're attached. You get 2 for 1.
Thank you so much. So Brenda speaks a lot about being together. And right now in our province, we are really working towards open family presence policies. Open family presence really means that we don't restrict families from being with their loved ones while in healthcare facilities. And we try to eliminate restricted visiting hours. And much of your experience would not be possible if visiting hours were in place, or if you were not allowed to go into the doctor's office or the flu clinic with your loved ones. So just thinking about when you have a patient, how can you always have their family there? Sometimes rooms are tight, sometimes it's hard because of privacy and confidentiality, but how can you help to overcome the barriers to make that possible? Because it really does create a positive experience. So thank you so much for sharing, Brenda. Alrighty, Leanne, a different question. Share an experience that could have been better.
Okay. First, I will say in all the years we've had so many positive experiences, and I don't want to appear negative, but there's just, when you're dealing with a son that's in the hospital for 4 years, there are things that come up that will affect his life forever. And the one experience that I think about was, like I said, my son was in PICU in Saskatoon, and the doctor there, we had a discussion with him regarding someone coming in to be with our son to help him to develop outside of what naturally happens in a hospital, which isn't a normal development for any child. So the PICU doctor would not let what we wanted happen. We wanted a therapist to come in from early childhood intervention, to come into PICU like maybe twice a week, to just play with him and just to treat him like a child. The head doctor was dead set against this, but we knew it was vital for him to have this happen as he was growing up, like I said, in a hospital environment, and developed later on a detachment disorder because of it. He would have gone home with any one of you and been quite okay with that. So he never really recognized us as his parents. We lived here, this was current, and he was in the hospital in Saskatoon. So we never did get this to happen for Blair, even though we know now that he developed autism, but the first years with that condition are so vital in a child's development, and big changes for the positive can happen with the right intervention early. It was a day that my husband and I still talk about. That doctor took us and a nurse into a quiet room in the hospital and made us sign a paper and told us that we should never ever bring that up to him again, and that the ICU had just about enough people in it without us involving people from the community. And so, in our naiveness, we signed the paper. I guess now, knowing from being on the committee here at the hospital, I know what I would have done now, but back then, I think we should have gone probably and talked to someone in management or someone like Susan, a quality care person, but we never even knew anything like that existed. So we felt very powerless. Now Blair has severe developmental delays, and we believe that that could have been helped back then, and would have been more, emotionally functional if we had pushed harder for this to happen. I believe the doctor was in error in this situation. I believe patients want more from their doctor than just their knowledge, like empathy, good communication, and putting the patient first, of course, and including them in decisions regarding their care. And I believe, too, that parents know their child the best. And with our son being in PICU for all that time, I believe that in rare situations such as ours, Blair needed this kind of attention to his development. And I know this doctor had maybe never had that happen before, because our son is the longest surviving ventilated patient in Canada at the time. So even though he was in ICU, I believe that they could have done a better job at making an exception in an exceptional case.
Thank you so much for sharing. It's always hard to share the challenging situations, but there's a lot to learn from that. Unfortunately, in my 5 or 6 years of working in patient family-centered care, I've heard a lot of patients share these contractual documents that they're asked to sign to stop a particular behavior. And I think they're fairly rare, but they should be a never event.
Yeah.
And so I encourage people to share their stories and help to identify, go to the quality of care coordinators whenever we find one of those rare circumstances where these agreements may exist, and really seek to eliminate them. I think they're quite rare, but we only know by people sharing their stories and bringing them forward. And so thank you for sharing that. And just as staff, think about, when do we ask people to do things that maybe don't necessarily resound with the pillars and the foundational concepts of being patient and family-centered and putting patients and families first. Righty, Brenda, we're back to you. So safety has been a priority of work for many patient family advisors. That's why we're here today at the Safety Expo. I'd like you to explain what makes you feel safe as a patient or family when receiving health services.
Well, first of all, we know one thing. There's only two kinds of error. There's human error and there's mechanical error. So knowing those two things, we know that, the healthcare organization, the government, everybody makes sure that mechanically everything is safe and operating the way it should be. But human error is more related to, it's subjective. It is based on how you feel about what you are and where you are. And you've noticed today already how emotional each of us is up here, and me in particular, because I'm hormonal. And and you know that when we come to you in healthcare safety, our emotional level is already very high. And oftentimes we're coming to you with a problem, with a trauma, with a healthcare issue that's maybe physical or neurological in nature. But the one thing that needs to happen with whatever it is, whether it's your broken leg, your children, and I don't belittle those situations at all, or my family member with his chronic issues. You as the healthcare provider need to think and be aware of my mental health, my emotional health. What is going on for me, with me, as I come to you? So what are the little things that you can do, or things that would make it easier for me to be more comfortable with who and what I am and what's going on with me at this moment in this healthcare experience? First thing you can do is acknowledge me. Say hello. There's no rocket science involved in welcoming someone into the healthcare facility or explaining and sharing with them along the way about what it is. It's that first impression. It's so important that whatever I'm feeling and experiencing is what I'm getting back from you in terms of whether you're available to me and you're focused on me and you're willing to help me. You know about your healthcare system. You know so much more about what happens here and how things work and how things need to progress a space. We as the patient and the family, we know about pressure. We know about cost. We know about those things, but we also know that if you could just take a few minutes to keep us informed, keep us aware, educate and engage me and my family, and the experience will go well for both of us. And so that's what safety means to me, is being engaged, being informed, and being educated. I know you can't be on your best at every minute of your 8-hour shift or 12-hour shift for every day for the entire time that you have your career, but when I engage with you, I really need you. I need you to make sure I don't have harm happen to me, because you know harm can happen. You might get a needle, for heaven's sakes. I hate needles. So I'm not trying to be humorous, but I am, because it's so simple.
Thank you so much. I actually want to share a bit of quote from what you wrote in preparation for today, because it's excellent. So she says, "Taking the time to listen to me or my family member is also very important. You may not have the answers, and that is okay. But being open and honest with me is very important. Tell me what you know and how you can help. And if you cannot help me, please be open and point me to where I need to go. You will not always have all the answers. I know that your time is limited, but don't ignore me and don't rush me. Engage me, educate me, hear my voice. Explain to me as best you can what your role will be in helping me, how long it will take, where I need to go, how to get there, what to expect. The more I know, the safer I will feel." And I think that really is what we're trying to accomplish with safety.
That's so true. Why didn't I say that?
You did say it. You wrote it. You did say it. You said it perfectly. And honestly, those are words that I'd love to be able to quote on in several different areas, because it is about empowering the patient to be a part of their care and accepting that we are human as staff and aren't going to be perfect. And no one expects that. So just being human and speaking, engaging in conversation and communicating really will help to improve safety culture. Alrighty, we're back to Melinda. So you're here today as a patient family advisor, and many people in this room know what a patient family advisor is, but this may be their first experience. So explain a little bit of your role as a patient family advisor and some of the things that you've been a part of.
Okay, I sort of stumbled into being a patient advisor. Beth Vachon had asked me to come and share my story with the board, which I did, and I bawled through the whole thing. I thought I was completely over the trauma of having a traumatic medical experience for a lengthy time, and it turns out I wasn't. And so I realized too that I needed to get over feeling probably private about it. I needed to get over feeling bitter about it, and I needed to turn that around differently. My head always knew that people make mistakes, or that things happen, but my heart didn't know it. So my head always said, I mean, this isn't the whole medical field, this just happened. But I was so busy trying not to be a victim that because I didn't want to be in that role at all. And so it was hard for me to get to the point where I thought I could help. So I sort of stumbled in a little bit, and I ended up, for some reason, on the provincial surgical oversight team. So that's the team of CEOs and surgeons in the province that figure out strategic direction for all of surgical in Saskatchewan. And so when I first went to the meeting, I thought, oh man, I am so in over my head. This is something. But what I found was a lot of things. I found out that at that level how much they care about their systems and about their hospitals and about patients. And they were really kind to me. They always explained what they were talking about when I looked puzzled, which was just about all the time. And they really valued my voice as a patient, and I got quite confident speaking as a patient Especially, I loved the part that I was a rural patient because I got to talk about the Wait 1 care, which I know what that means now. It means, before you get to see the surgeon.
Awesome.
Yeah, I know. And there are some really great people on that team. And there are some other people that reinforce the bad reputations that some doctors would get. And they talked a lot about how things will work in other areas, and I've had to learn some things about my own hospital that I don't know because there's no one else from Cyprus that's on that. So I have to get a hold of my own doctor and say, are our surgical rooms filled all the time or aren't they? Those kinds of questions. And I can't tell you that I would have never imagined myself having to find out that answer on the Provincial Surgical Oversight Team. It's been really an amazing experience. And I'm so grateful that they want the patient's view on that. And it's always a little different than lots of the surgeons, although there's one guy on there who's just spot on and always is great. But, and then I participated in the RPIW not too long ago, and I loved that too. It was a wonderful, wonderful experience. And again, I felt so respected as a patient, and that my view was there. And this is what else I learned. My view is needed. The patient view is needed because we get really caught up in the accountability and the efficiency and how much we have to do and how busy we are, that view does get missed. And I'm so glad that our province is really focusing on that.
Thank you so much. So there's a few things I just wanted to comment on, Melinda. First of all, patient family advisors do hard work. They don't come to a committee meeting and just sit there, share their story, and go home at the end of the day. They actively participate. They create documents. They create strategies for advancing patient family-centered care, as well as improving quality of care for patients and families in many different ways. There's patient family advisors involved at various levels. So you heard in a rapid process improvement workshop, a unit level improvement workshop, all the way up to strategic committees at a provincial governance level. So the role and the voice of patients and families is really embedded throughout the healthcare system. And so I think that really speaks to, it is a role, it is hard work, it's not a token, it's not, you're actively participating. So thank you so much for sharing. I learned a lot from your response. Brenda, would you like to answer the same question? Just explaining your role as a patient family advisor and some of the work that you've been involved in.
It's the best experiences I've ever had, and they always meet my expectations or far exceed any expectations that I could have. But I've done 3 different scenarios. One was an RPIW right here in the Swift Current Hospital around pre-surgical wait list, not at your level, but just at a nice local level, the grassroots. And every time now when I come to the Swift Current Hospital, I get the feeling like this is my home. And if I need to use a phone, I know where it is on the 2nd floor. And not just that, but the whole time that I was here that week, it was the more time you spend in a healthcare center facility, the more comfortable you come with the routines, with the staff, and you really get a sense of how hardworking and how focused and dedicated everyone is to what they're doing. So that was my hospital experience. Now I got to tell you about the Cypress Lodge in Maple Creek. And, they've moved over to their new digs at the hospital or at the primary health center there. And my very first job in healthcare ever was in 1972. I was 18 years old and I worked as a care aide at the Cypress Lodge in Maple Creek. Scared the crap out of me. And there I was. I went back there 2 years ago as a patient family rep, and our focus was looking at in this very outdated, confined, difficult working space, difficult living space for the residents and the staff at the Maple Creek Cypress Lodge. And it was part of that RPIW was to look at how meds are delivered. And you can't imagine the chaos, the confinement, the stress that everyone who lived and worked in that care environment would feel and experience every minute of their day, and their working day or their living day, because The residents live there, the staff come to work there. But the sense of family, the sense of community, the sense of commitment, the intense hospitality that I received in that week that I was there, it's a high you can't replace. And I would never have had that experience if I hadn't had this opportunity. If I hadn't got mad at the healthcare system and decided to become a patient family advocate. But I got to tell you about one more, because not only did I go from acute care to long-term care, I'm currently involved with a committee working, looking at mental health wait lists for people who are like me. You know, they got a little bit of anxiety, they got a, you know, they're not sick enough or need to be hospitalized, but they need to see a therapist, they need mental health services, they need community mental health. And so there's a waiting list that's very long, and the provincial government has said, we got to look at ways of making it more user-friendly for everyone involved, especially in a rural health region like this. You know, it's 60 miles to Maple Creek. It's at least that to Mankota or to Leader or to Shaunavon. And, you know, you just don't go down the street to get what you need. Sometimes you got to drive for an hour, and you got to find a driver, and you got to figure out how to get there. And there's a lot of complications and things that have to happen before you can actually even get the health care that you're looking for. And so this committee, this mental health subcommittee, is looking at ways of providing health care, community mental health services to the entire region, not just the people who live in Swift-Current, but those who live in our outlying areas, and looking at ways to make it, I keep saying user-friendly, but my new buzzwords are engage me and educate me. And if you can do those two things, I'm a happy camper. And I can't believe how my voice, and my mother always said I talk too much, but they listen, they hear, and they respect what I have to say. The same experience that Melinda had. And you as the infrastructure, you have no idea what it means for someone like me to have my voice heard and to be able to participate. So it's not what you give me, it's not what I give you, it's what I get in return. And that's what makes it unique and special, to be a part of things that are going on in our health region. And thank you for having me for that.
Absolutely. The patient lens is definitely different than the staff lens. So often we find that, you know, as staff, we think, I know what patients and families will need. I've been a healthcare provider for years and years, or what have you, and a physician or a nurse or social worker may say those things. But listening to a patient family advisor who's currently going through it, there are different perspectives, and the perspective is so important. So I agree, it's important to have patients and families involved. I just want to pick up on the fact that you spoke about 3 different areas. So patient-family-centered care crosses the boundaries of community care, acute care, and long-term care. It's not just one area that we need to focus our efforts in advancing patient-family-centered care. So I appreciate you bringing that up. And also just talking about accessibility. You know, we often forget that getting to the appointments or getting to the healthcare system is sometimes more of a challenge than the care itself.
Absolutely.
And so, you know, taking that look at how accessible the health services are is really important. Thanks for sharing. So, Leanne, what is one project that you've worked on that you think has improved care?
Probably about 2 years ago, I was asked to go into the wards here at the hospital, and I was given a set of questions. I would go into different patients' rooms, and I would survey them regarding their health, their stay in the hospital. And then these surveys were submitted to those that were looking them over. And when I went to visit these people, it was just so apparent that, like, first they'd say, I mean, you actually want to hear about my hospital stay? Like, they were surprised that someone would come and do that, for starters. And so it was exciting. It was a real high for me too, like these girls said, to talk with these people and to have them answer the questions. And they were their concerns were many, and they were very passionate about things they said. Many people started to cry. I could have stayed in each room for an hour. Like, it was all I could do to get on to my next patient, because I had to have them done in a certain time frame. And I was told not to stay too long, but that was almost an impossibility. And I loved talking to these people. And the time just flew, but it took way longer than I was supposed to. But I submitted the surveys to those in charge, and they were given a glimpse of how these patients feel. about their stay, and they all wanted to be heard. Not one person was hesitant at all. And I would hope that those efforts, even in just a small way, would help those in charge of those people to, see how these patients felt. And it was so exciting for these people to have a voice. And I just hope that that helps in some way for the process to move forward.
Great, thank you. So what Leanne was speaking about was the patient experience survey, which is a tool that you can take to the bedside and have the patient either complete on an iPad or on a paper copy. And we find that when other patient family advisors go to the bedside and actually ask those questions, the response rate is much greater and the value of the responses is great. And so, many health regions have embarked on that. It's a hard task because it's very labor intensive. You have to go to the bedside, but it's not something you have to do all the time. You can do spot audits, just kind of see how things are going. Oh, we've made a big change on this unit. Let's see if things are getting better, or maybe we've created new problems that we didn't anticipate. Alternatively, in Regina Capel Health Region, what they do is they actually have their manager or their shift coordinator out doing these conversational questionnaires, and they ask similar questions that are on the experience survey, and they just try and get 2 to 3 a day, and then they report those back up at the daily visual management huddles. And so it's just a way to kind of see how are things really going in a human element, not necessarily such a rigorous, statistically valid survey, but rather just conversational data that helps you to understand where things are at on your unit on any given day. So thanks for sharing. That's a great best practice for patient-family-centered care to discuss. So Melinda, what has been the most rewarding part about being a patient-family advisor?
Definitely feeling useful is the most rewarding thing. I really think our health system has made the best use of lean that I know of. My own ministry is involved with lean, but I'll tell you, the quality of work being done in the medical system is, you should all be so proud of yourselves because I think it's real honorable and honest work that's being done. I have not been part of anything that I haven't felt things were trying to be more efficient, but better care. And so the care isn't like you say, the actual knowledge that you've learned about how to give needles and how to, it's the care.
Caring.
Yeah, and it's that caring piece, and there's no one that got involved in the medical system, I've learned through these processes, that isn't there because they don't care about people. No one wants to be a doctor because they don't care about people, and no one wants to be a nurse because they're shy about being with anybody. That's not why they do it. They care, and yet we pulled them away from that so far, and I really feel like lean is pulling us back to that. So I think the rewarding thing is really seeing good work being done. Really best practice lean work is being done in the medical system. There's no question, in my mind, after having been part of that. And I think I've learned. I think I've learned to be confident that I can speak for other patients, and that I am Joe Blow on the street when it comes to when I'm in that bed and I'm vulnerable, and I really just want you to find a way for me to have any shred of dignity that I can. Yes. And I'm able to talk about that, whether it's on the provincial surgical oversight team or in an RPW, or now when I go about my flu shots and medical things, and now with my parents, with them in the hospital and helping in those ways, I do not feel bad about asking questions and being braver. And I would have thought I've always been a pretty brave person about standing up for myself, and it isn't true when you're in a hospital bed. It isn't. And it isn't true when it's your dad in the hospital bed. It just doesn't work that way. Yes. You are shaken off your core, no matter how confident you are in real life. And you need that care and the knowledge. You're right, very right, Brenda, about that. That makes all the difference. Yeah.
I really appreciate your responses because I know that it is hard to speak up. Even myself, as patient family-centered care lead, I've had encounters with the healthcare system where I haven't felt confident and comfortable to speak up. So I think about the individual who truly is vulnerable, who isn't maybe educated or doesn't speak fluent English. How would they ever advocate and speak up for themselves? It boggles my mind. And so just giving people the opportunity to speak up, to be listened to, and the time that takes, a very important point. So thank you for kind of bringing that up. I want to ask a little bit about this word dignity. We're going to go off our sheet here if you guys are okay with that. Because when you said the word dignity, you all nodded your head. So let's talk about, what does dignity mean for you as patients or as families? What does it look like?
Well, I think nurses and doctors are used to seeing people with their gowns all over the place and naked people and all kinds of things, and they're used to it, but I'm not used to that being me there. I'm not. It is a level playing field for every patient when you're in that bed, and the small dignities of being treated like a person. Being treated with dignity, that it matters and you're important. That message, you're important. You say
Dignity is also a two-way street. It's you are aware of me and who I am as an individual, and I got a lot of quirks, believe me, I do. But when I come to you, I am giving you my most vulnerable self, as is my family member. And dignity for me is that you stop in the midst of what it is that's going on in your busy work world and day, and it's little things like the housekeeper saying, hey, I'm here to clean your room. It doesn't matter where you're on the food chain in the healthcare system. It matters that you're there and you're needed there, and how you treat me with respect and dignity says everything about how my experience is going to go. That's what dignity is for me.
And I was worried about especially in our region, all those old farmers that it took their wives weeks to drag in here, to get on. They aren't gonna tell you what they need to tell you, and the wife's trying. And I'm thinking about those doctors, and if somebody just whizzes in and says, "Oh, jump sugar, yeah," and doesn't dig a little bit with those guys, you're not going to get the answer that, yeah, I'm not feeling that great today. Doesn't mean, on a scale of 1 to 10, when he says 2, add on 5. That dignity of understanding who you're dealing with, and that people's pride is a huge issue, and you need to really get through that. And it takes probably experience and practice, but that's a dignified response to a patient.
I think it's little things that, introducing yourself. Like, I know my sons really respond to someone who's just a little bit jokey and teasy, and then they think, oh, she's not a nurse anymore, she's now my friend. And I know that's what makes my sons feel comfortable when they're in the hospital setting. Just being you.
It's the opposite of feeling like a nuisance.
Yes.
Exactly. Yeah. Exactly.
That's excellent. And I think that is something we do hear from patients and families a lot of the time, which I don't understand, that they feel like a nuisance when they're coming to the healthcare system. And I always tell people, you shouldn't feel like a nuisance, because we wouldn't all have jobs if there weren't patients and families needing care. And so that is the work that we all want to do by working in healthcare in one form or another. And so, how do we change that as a culture, that patients and families don't feel like a nuisance when they come to the facility or that they're receiving care? And I think the other thing that you guys spoke about a little bit is that it may be the first time as a patient you're experiencing something. So whether that's the first time you are using a commode, the first time you have a catheter, things like that. It's not the first time for the nurse. or the physician. They've been through that rodeo many times and they understand.
I don't like that rodeo.
But it's your first time, and so how do you prepare people for their first time through an experience? I find that is a huge piece of dignity and respect. So we have time for one more question. So Leanne, I'm going to go over to you. What is one thing that you think is important for the healthcare teams to do to become more patient and family centered?
It just brings me back to a time in the hospital when my son happened to be in the hospital over the Christmas season one year. And I just remember how difficult that was. We missed every occasion that we had looked forward to the entire fall. And I just remember on Christmas Day, there wasn't a word said on the ward that it was even Christmas. And I just thought there were so many things that could have helped our family not feel gypped like we did. And I believe that the most important thing is to help in what we were just talking about, here, is to make the patient not feel like a bother, and that they matter in the big scheme of the ward, even though there's lots of other people, and we all know that. But many people feel very alone, and just by the nurse introducing herself, calling the patient by name, smiling when you come into the room, things like that, help us to feel welcome there. And I think the main thing would be to go above and beyond. If you have just a minute to do one thing that out of your schedule checklist, just makes it so much easier. And just remember that if you're giving a patient bad news, that we have lots of that your face and how you said what you said may be what that patient remembers for the rest of their life. Like they've never been given that news before. And I think to just go the extra mile to just take care, for certain situations, and just lightens everything. So.
Excellent. Thank you so much. Thank you to all of you for sharing and for all of you for attending today. I'd like to pass it over to... Oh, we're here. Come on up. I can see you hiding behind the camera there.
Thanks. You're passing it over to Larry Stevens. I'm one of the board members here, and I want to begin by thanking Beth for inviting me to offer the closing remarks. I really do consider it a privilege to have been asked and to be privy to what was discussed here. It's been a while since I've done any public speaking. It's taking a bit of courage for me to admit to this, but at least I'm not bearing my soul the way you ladies have, and I have to say how much I commend you for the courage that you're displaying sitting in on this kind of discussion.
Thank you.
If there's a couple of things that I want to take away from this, it's some of the remarks that Brenda has made about engaging and educating, and the discussion on dignity and vulnerability. It says so much about the healthcare system, and what I see happening here is getting right down to the grassroots. What I'd like to do for just a moment, though, is to back up and really look at a broader picture. And I have to share this with you. This is a short history of medicine. 2000 BC, doctor, I have an earache. And the doctor says, here, eat this root. 1000 BC, the doctor says, that root is heathen, say this prayer. In 1850 AD, the prayer is superstitious, drink this potion. In 1940, this potion is snake oil, swallow this pill. In 1985, this pill is ineffective, take this antibiotic. Now in 2015, that antibiotic is artificial. Here, eat this root. So there we've come full circle. What I look at is the proof that we as human beings are acting as gods. I look at the advances in the field of medicine, and I've kind of done it really broadly, looking at reproductive medicine. I don't know where we are now but I know that we can really do great things. Going beyond that, we can look at curing the sick, we can look at prolonging life, and in some cases we can even look at restoring life. We've got the paddles. But then, just as we're kind of patting ourselves on the back because we've come so far, something untoward should happen to a patient. And we're thinking that we can run with the gods, and we can't. And what that's brought to me is these experiences here that these ladies have shared.